Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a traumatic cataract. He's a 42-year-old person. He had a lot of trouble holding the eye still. And so I'm going to show you some of the techniques and maneuvers beyond just talking to the patient and calming him down throughout the surgery, just really using some techniques to help control the eye, namely using a two-handed technique at all times. First, I use a cotton tip, and then I'll use a BSS cannula through the paracentesis to help manipulate and stabilize the eye. So you can see this patient has a pretty dense PSC component to his cataract. He has a very strong Bell's reflex. This is the left eye. You can see the left eye is trying to turn upward. I'm using the cotton tip to hold the eye steady and using a corneal mark to help me center incisor-rhexis. His Bell's reflex is so strong, I'm using a cotton tip to turn the eye way down. I'm asking him to look down. And then I'm using my paracentesis to make my incision, first on the right side and then on the left side. The left side is a lot easier since he's already looking upward. So this entire time I'm trying to help him, relax. We're playing music in the background. I'm talking to him. You can see every movement I'm doing, he's kind of reacting. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic. I'm using the cannula to turn the eye downward, and I'm using kind of like this Orlock technique where I'm rotating the eye and I'm rotating the cannula to help fixate the cannula and to keeping the eye straight. I make my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. That's the triplanar corneal incision. And again, this patient is not going to be able to control his eye. And I guess I could have done a block technique, but now that we're in here, I felt pretty confident I can otherwise try to manipulate the eye. And so using the cannula to hold the eye steady, make my puncture style capsulorhexis. I puncture centrally and pull down towards me. I grab the right side of the capsule, which creates a nice little flap. And then I'm going around circumferentially. You can see it's a pretty dense PSC cataract. I had a little bit of trouble finding the edge, and then I found it. I'm just going around very carefully, again, using that cannula to hold the eye nice and steady and straight. Because of his very strong Bell's reflex, he really wasn't able to keep the eye straight on his own. I go ahead and finish off the rhexis and burp some viscoelastic out. And then I'm going to begin the capsular fornix hydrodissection technique. Place the cannula out to the contralateral equator underneath the rhexis edge, point the tip down, get a nice fluid wave. I'm going to decompress on the left side. It doesn't really do anything. And then on the right side. Again, this is a young patient. It's primarily a PSC component cataract. But because I didn't want to spin the lens in this situation because it cheese wires, I went ahead and did a hydrodelineation. You saw that I pointed the tip down into the meat of the lens. So I'm irrigating the cornea. You can see how reactive he is. And then I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And then I'm removing the surface epinuclear material. You can see it again, this is a soft lens. I did the hydrodelineation, and lo and behold, it just pulls the lens piece up, out very nicely. And so that is a nice tip, especially with these soft lenses that are difficult to turn. Just did a nice hydrodelineation, and the lens just came out really nicely. So in the same mode, I'm going to start to remove the epinuclear material, and you can see it just pops out really, really easily. I didn't have to spin the lens at all, minimizing any zonular stress. So I take the chopper out, push BSS in, take the phaco tip out, and then switch it to the INA. I start subincisionally removing the cortical material from anterior and posterior, peeling it off. I'm going around circumferentially. I'm just turning the sleeve a little bit, making sure it's nice and flush. And then I'm polishing underneath the rhexis edge. You can see the posterior capsule may have some, could be fibrotic material because of the traumatic nature of the cataract. But I'm going to go ahead and polish the posterior capsule surface as much as I can as well. I start subincisionally polishing the subincisional area as well as the posterior capsule in that area. You can see a lot of that posterior capsule material is fibrotic. So I'm going to push BSS into the subincisional capsular fornix. It looks pretty clean here. And then I'm injecting some cohesive viscoelastic to fill the capsular bag. And then I'm going to start to sweep underneath the rhexis edge, first on the left side. And then on the right side. I'm going to inject a single piece acrylic intraocular lens into the capsular bag. I'm injecting the leading edge into the bag and leaving the trailing edge out of the bag. While it's unfolding, I go ahead and put the INA handpiece in with irrigation off, activate irrigation, and then disengage the leading haptic and then trailing haptic, go underneath the optic, tilting it and then rotating it 90 degrees, and removing the viscoelastic from within the bag. By doing it this way, I ensure that both haptics are definitely in the bag. You can see now I'm rotating the haptics horizontally, and now I'm polishing underneath the rhexis edge. I switch to the visco mode to remove all the viscoelastic from the anterior chamber. And then I'll hydrate my incision. So you can see this is a patient who had a traumatic cataract, a very large PSC component, with very soft lens, and as a result, I did a hydrodelineation, which allowed the lens to really, the endonucleus was able to prolapse really nicely out of the bag, and then the epinucleus in consecutive fashion. I'm using the cannula to help manipulate the eye and control the eye in order to do my triplanar corneal incision as well as my capsulorhexis. So by using a two-handed technique, you're able to take these cases where the patient is not really very compliant, using a cotton tip in the beginning and then using my cannula to help manipulate the eye through the paracentesis incision. This really gives me a two-handed control whenever I'm dealing with patients who have trouble controlling the eye. So I hope this was helpful to you, and I thank you for your attention.